Hey everyone, it's Viscerverse, where we dissect medical jargon into simpler topics. And today we're going to dissect penicillin. Penicillin is a really interesting topic. Penicillin was the first antibiotic to be discovered. So it is considered the OG of all antibiotics. It was first discovered in mold. So in a fungus called fungus Penicillium, we discovered or we derived penicillin. Here, we see the structure of penicillin. You don't really have to know the structure, but what you really need to know is that this structure contains a Beta-Lactam ring. It's not only found in penicillin, it's also found in carbapenems and cephalosporins, but the only ring that is found in penicillin is called the thiazolidine ring. This is the arch chain, or the side chain. And so we're going to talk in this lecture about the normal penicillins that are found in fungus and the semi-synthetic ones that are modified in the lab. So what is the mechanism of penicillin? How do we use it to kill bacteria? To understand this, we have to understand that the bacterial cell wall is actually a dynamic structure. So it's constantly forming and breaking down specific molecules because it is dynamic. So a simple analogy we can look at our bones, and when we look at our bones, we can see that we have osteoblasts and osteoclasts. So osteoblasts build the bone and the breakdown is done by osteoclasts. And with that being said, we can form a balance between these. Same thing goes for the bacteria. One of the most important enzymes that are used is a transpeptidase. A transpeptidase is important because what it's really doing is that in the cell wall, we have peptidoglycans. Here on the screen, you can see a form of peptidoglycans and how it looks. Typically, every chain of these would end with alanine, with 2 alanine residues. The transpeptidase would come and it would bind to the 1,2 and 1,2 alanine residues. Now, when it does that, it cross-links an alanine and a lysine. When this happens, we have a stiff, working, dynamic cell wall that aids in the protection of the bacteria. Now, once you understand how a transpeptidase work, we can understand how penicillin work. Penicillin would come and it would block the binding site of the transpeptidase. When it does that, the transpeptidase is no longer able to cross-link the peptidoglycans of the cell wall, and therefore it goes through autolysis. So this makes penicillins called bactericidal. So penicillin is bactericidal. And again, as we've said before, we have 2 forms of penicillin. One is penicillin G, and we have the IV and the intramuscular forms. And then for the penicillin V, it's oral. Sometimes oftentimes, bacteria is really clever. So what it does, it is with a specific clever mechanisms, it would overcome penicillin in what we call penicillin resistance. We have 3 important mechanisms. One is modified penicillin binding proteins. So what really happens, as we've seen previously, the penicillin would come and it would dock right here on the transpeptidase perfectly, that it blocks this peptidase from binding to the peptidoglycans, which is the ALA residues, and therefore no cross-linking happens. Now, sometimes the bacteria would change and do some genetic mutations, gene mutations that would change the shape or modify the transpeptidase. Now, when we have this, the penicillin will no longer be able to bind to the transpeptidase. So it can keep going and cross-link this peptidoglycan to form a well-working cell wall. The second mechanism that bacteria use, especially in gram-negative bacteria, is that it reduces penetration. The cell penetration is reduced. And how does it do that? Now, typically in gram-negative bacteria, we have specific pores called porins. These porins are important for bacteria to get their own nutrients. Sometimes what it does is that it just reduces the number. So instead of having 2, for instance, here, it would just kick one out and keep the second one. A third important mechanism, probably one of the most important mechanisms here, is beta-lactamase enzyme. The beta-lactamase enzyme is a clever enzyme. It would go to the beta-lactam ring and just cut it, rendering penicillin inactive, and therefore we no longer have any effect of penicillin. We will talk later about the beta-lactamase inhibitors, but it's important to keep in mind for now is that we have specific inhibitors that we can use with penicillin to help it avoid this beta-lactamase activity, including clavulanic acid, sulbactam, and tazobactam. Now that we understand what penicillin is, its structure, and how it works, let's discuss its side effects. I remember one day, one of our doctors told us that every medication has side effects. And if it doesn't, that means it's not working. But when it does, although it varies from patient to patient, it means that it's working. So let's discuss the adverse effects of penicillin. The first one we'll talk about is a hypersensitivity reaction, which is type 1 hypersensitivity reaction that is associated or IgE mediated. And because it's IgE mediated, we can see that this is actually an acute reaction. The patient would typically present with hives as seen on the screen here. The second important complication we're going to talk about is maculopapular rash. This is a bit more chronic. It takes days. It's chronic, and it takes from days up to weeks to appear. And because of that, we can tell that this is a type 4 sensitivity reaction. It is T-cell mediated, and typically the typical scenario for the maculopapular rash is that a patient would come and would present with a clinical scenario that is very, very similar to a strep throat. However, this is actually confused with EBV. EBV pharyngitis, it mimics strep throat to the extent that a lot of doctors would confuse that. And because we think it's a bacterial infection, we tend to give them a penicillin. And because of that, because of a reaction that is not really well known, the mechanism is not known, the patient would develop a maculopapular rash typically 1 to 2 days after we give the medication. And this rash does not present with any systemic symptoms like fever, so just a rash as seen on the screen here. So this is really important to keep in mind. We will talk about which type of penicillin exactly causes this. It's from the family of aminopenicillins. So we're going to talk about this in the next lesson. The next important side effect here is Stevens-Johnson syndrome, and the more severe form of Stevens-Johnson syndrome, which is toxic epidermal necrolysis. What really happens here is that we have a destruction of the skin, a sloughing of the skin at the dermal-epidermal junction. So the patients would typically present like this. They have a lot of blisters and vesicles, and this, when it's Stevens-Johnson syndrome, we typically have an involvement of the skin that is less than 10%. If it exceeds 30%, we call this toxic epidermal necrolysis. And if we have it somewhere between 11 to 29%, we say that this is overlap between the two syndromes. Another important side effect is drug-induced interstitial nephritis. In this situation, the penicillin acts as a hapten. And what a hapten is, it is a very small molecule. Just like penicillin, it's very tiny that the immune system cannot really see it. However, sometimes when this happens, when we have interstitial nephritis, what is really happening here is that we have antigen complex. This penicillin that the immune system is not seeing at all would go and when it would bind to a protein. When it binds to a protein, it forms an antigen complex. When this happens, then the immune system is activated and it sees this as a foreign body, and then it would attack it. So a hapten is a small molecule that forms an antigen molecules, and because of the antigen complex, the immune system is alert and it would attack it. So we have the so-called drug-induced interstitial nephritis, and it typically presents with specific clinical presentation, including fever, oliguria, and because we're not filtering the BUN and creatinine, the ratios can increase, eosinophils are going to be found in the urine, and WBC casts. However, this is not an infection. The WBC cast here, we see it in a sterile urea. The cause is a drug. It is the penicillin, not an infection. Moving to the next important side effect, it's hemolytic anemia. So again, this tiny molecule, penicillin, is acting as a hapten. Only when it binds to RBCs that the immune system is alert and it will attack it. This leads to hemolytic anemia. Another important complication is serum sickness. In serum sickness, we have an immune complex disorder in which we have the IgG deposits in tissues. When this happens, we have a complement system activation. And then patients would present with symptoms including fever, arthritis, and lymphadenopathy. Another important complication that we see, or a side effect, now, as opposed to all of the side effects that we saw previously, here we have the Jarisch-Herxheimer reaction. Here, we have the patient 2 hours post-antibiotic, they would develop fever, chills, and hyperventilation. The reason is, here, it's not due to an immune allergic reaction, but it's rather due to an immune response due to bacterial death. You give the antibiotic, the bacteria is dying, and because of this dying bacteria, we have an immune response. This especially happens in syphilis. So this is the end of our lesson about penicillins. If you like the video, give it a thumbs up, subscribe to the channel, and check our website to get these illustrations as well as a note for free. In the next lecture, we're going to talk about the semi-synthetic penicillins, that is, the ones that are sensitive or resistant to penicillinase.